I dream a world where man no other man will scorn, where love will bless the earth and peace its paths adorn. I dream a world where all will know sweet freedom's way, where greed no longer saps the soul nor avarice blights our day. A world I dream where black or white, whatever race you be, will share the bounties of the earth and every man is free, where wretchedness will hang its head and joy, like a pearl, attends the needs of all mankind. Of such I dream, my world. Langston Hughes. So let's talk a little bit about how we got here and why we're having this conversation. So 30 years ago, the Heckler Report came out under the administration, actually, of Ronald Reagan. This report outlined 6 causes of what we now call excess mortality, and obviously we think in terms of disparity today, but it was called excess mortality then. The 6 causes were cancer, cardiovascular disease, cerebrovascular disease, chemical dependency, diabetes, homicide, suicide, and accidents, and infant mortality. But because this report was released in 1985, soon after the report was released, HIV/AIDS was added to the list. If we look at our data today, we see that while we may have made some progress, we certainly haven't made enough. So that we see that African Americans still die at disproportionately higher rates from heart disease, cerebrovascular disease, cancer, diabetes, renal disease. We see that American Indians are more likely to die from accidents and motor vehicle accidents. African Americans disproportionately more likely to die from HIV/AIDS. Whites significantly more likely to die from suicide, while African Americans are much, much more likely to be murdered. If we look at infant mortality, again, we see this notion of excess mortality that reared its ugly head in '85, continuing to rear its ugly head, with not actually a whole lot of progress in narrowing the gap in disparity between blacks and whites in this country. And all of that, of course, means that there are higher age-adjusted death rates for African Americans in the United States compared to others. And this is what life expectancy looks like both by race as well as by gender, with black men having the lowest life expectancy and white women having the greatest life expectancy. The sad news that probably many of you have heard is that we've made some progress with black men living longer, still at the bottom of the curve, but living somewhat longer. But we're seeing white women actually, life expectancy decreasing somewhat related to suicide and substance abuse. So in 2003, the Institute of Medicine published a report called Unequal Treatment. And the purpose of this report was both to document as well as to make some recommendations for what we might begin to do to eliminate health disparities. Evidence of racial and ethnic disparities in healthcare is, with few exceptions, remarkably consistent across a range of illnesses and healthcare services. These disparities are associated with socioeconomic differences and tend to diminish significantly, and in a few cases disappear altogether when socioeconomic factors are controlled. And one of the things actually that was discussed when the Heckler report first came out was how much was that report actually a proxy for poverty versus actually a reflection of what was going on by race. However, the majority of studies find that racial and ethnic disparities remain even after adjustment for socioeconomic differences and other healthcare access-related factors. So what that tells us is certainly poverty is an issue, and poverty is an issue for people in this country related to health outcomes, regardless of race. But there is another aspect to disparity that's solely related to race ethnicity. Racial and ethnic disparities in healthcare occur in the context of broader historic and contemporary social and economic inequality and evidence of persistent racial and ethnic discrimination in many sectors of American life. That was written in 2003. Certainly, it's as relevant in 2016. So we look at these factors that affect health. Obviously, we know socioeconomic factors are huge. What we do in our clinical world pales in comparison to the reality of social economics on the outcomes for people's lives. The Robert Wood Johnson Foundation partnered with the University of Wisconsin to create county health rankings. If you haven't gone to this website, I urge you to go to this website. Actually, because New York City is all of the boroughs or counties, there's a lot of very rich data related to how the boroughs are doing. And basically, the framework that's used by county health rankings is really this framework that basically says that socioeconomic factors and physical environment account for about 50% of both morbidity and mortality, and that what we really are looking at in the rankings is both length of life as well as quality of life. Again, clinical care, what we do, that counts for about 20%. An important 20%, don't get me wrong. Very important, and we know that when people don't have access to it. But it misses the big picture in terms of what's really impacting our patients' health. This is from the World Health Organization. Social determinants of health are the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces, economics, social policies, and we can never forget politics. So I'm going to show you some data. I'm less interested in you memorizing the numbers and more interested in you paying attention to the proportionality. So we see that in the United States, African Americans make the lowest median household income, 2010 to 2014, with Asians actually having the overall highest median household income. If we look at the wealth gap by race, we get a window into some of the extensive challenges faced by African Americans compared to whites when it comes to economic security. We see actually that the wealth gap has been growing. There was a period of time around 2000 when it started to narrow, and it's now growing again, so that white net worth is about 13 times greater than that for African Americans and 10 times greater than net worth for Hispanics. This is another visual way to look at those numbers. So if we look at the factors that impact the wealth gap, we see that the largest factor actually relates to years of home ownership. But we also see factors like income, rates of unemployment, obviously the lower the better, years of college education, financial support, and starting wealth in 1984. And we have a lot of talk and a lot of reality that the rich get richer. And this would seem to bear that out. From Oliver and Shapiro's book, Black Wealth, White Wealth, we are reminded that African Americans were basically locked out of an ability to get appropriate home loans for their homes by the FHA. The federal government had a policy that actually steered African Americans away from the same types of loans that their white counterparts were able to get regardless of income. And what that meant was that African Americans were then redlined. You probably have heard this term. Basically, it means that not only were people steered to live in certain areas, but those areas were then judged to be less viable than other areas. And so the increasing poverty in these neighborhoods became a self-fulfilling prophecy. I'm going to go back for a minute and talk about income, and we see that same trends that we see with wealth, so that African Americans are less likely to get the same income. This was one of the most remarkable pieces of data that I came upon, and this analysis was actually done by some researchers at Columbia, and basically what it looked at is sort of the poorest of the poor by race ethnicity, right? And so what we see is that from 2011, 2012, and 2013, the poorest of the poor Asians earned $15,000 a year, $13,200 a year, and $19,000 a year. we see that whites earned about $10,000 for the first 2 years and $12,000 in 2013. What's remarkable is to look at the numbers for African Americans and Latinos. No income whatsoever. $1,000 of income for Latinos in 2013. This is the difference in what it means to be poor by race, ethnicity, as well in this country, to be categorized as the poorest of the poor. What we also know is that there's disparity in life expectancy by income. And so the life expectancy for the bottom 10% of male wage earners, that would be those people in the category of numbers I showed you in the previous slide, for those people born in 1920, by the way, most of these people have passed, but their life expectancy was about 23 years, and the life expectancy for the top 10% of earners from 1920, born in 1920, was 79 years with a gap of 6.2 years. If we look, however, at people born in 1950, we see that that gap has widened to nearly 14 years. So the poorest of the poor are living I don't even know if we'd call this reasonable life expectancy compared to those born in 1920, but we certainly see that they are not coming close to making the gains in life expectancy that the richest of the rich are having. So I thought I'd bring you to your own neighborhood here. So these maps, by the way, are available. If you just Google Robert Wood Johnson Foundation, you can pull these up. But so here we are in East Harlem, which is a few blocks from you. When we see the life expectancy, average life expectancy is 76 years, and we go down to the Lower East Side to Murray Hill, and life expectancy is 85 years. Verifying, again, the term when we say your zip code is more important than your genetic code. That clearly gets demonstrated in these maps. And I threw in Chicago just so you wouldn't think that New York is alone in its geographic disparity. And of course, you are not. The truth of the matter is there are maps like this for every major city in this country. So Ta-Nehisi Coates wrote an article in The Atlantic in June of 2014 making the case for reparations. Don't worry, you can exhale. I'm not going to stand before you and make the case for reparations. But what I am going to do is to talk about some of the documentation that Ta-Nehisi Coates and some of the realities that he outlined in his article. Again, we have to keep coming back to this notion of what it means to not be able to own a home in a good neighborhood in the United States. And so we see from a brochure from the National Association of Real Estate Boards that that colored men of means who were giving their children a college education and thought they were entitled to live among whites were viewed as poorly as madams, bootleggers, and gangsters. In other words, these were the last people you wanted to steer to live in what was considered at the time to be good, solid, middle-class white neighborhoods. This is from their brochure. So Sharkey and colleagues looked at children born from 1955 to 70 and found that 4% of whites and 62% of blacks across America had been raised in poor neighborhoods. He looked a generation later and basically showed that nothing had changed. That whites born into affluent neighborhoods continued to live in affluent neighborhoods, whereas in some cases blacks tended to fall out of affluent neighborhoods in much higher proportion than whites. So we take the brochure from 1943, and then we talk about the recent housing crisis that we had in this country related to countrywide and loans and the like. And obviously we look at Wells Fargo. So in 2005, they put out this campaign that said, we're going to make more people of color be able to buy their own houses, and we're going to give you affordable loans, and you too can have the new middle-class standard and develop generational wealth. And in 2010, the Justice Department filed a discrimination suit against them because they disproportionately shunted African Americans into these predatory loans, regardless of their creditworthiness. So what that meant was that black home buyers, even after controlling for factors like creditworthiness, were still more likely than white home buyers to be steered towards subprime loans. Some of you may remember what happened with these loans. Also, according to the New York Times, affidavits found loan officers referring to their black customers as mud people and to their subprime products as ghetto loans. In 2011, Bank of America agreed to pay $355 million to settle charges of discrimination against its countrywide unit, and the following year, Wells Fargo settled a discrimination suit for more than $175 million. Not quite the same tactics as the realtors from 1943, but certainly one could argue similar effects. So in 2009, half the properties in Baltimore whose owners had been granted loans by Wells Fargo between 2005 and 2008 were vacant. Half the properties whose owners had been granted loans by Wells Fargo between 2005 and 2008 were vacant. 71% of those properties were in predominantly black neighborhoods. Let's talk about what it means to have vacant properties in neighborhoods and what it does to the stability of those neighborhoods and the safety of those neighborhoods and the aesthetic of those neighborhoods. This is a cartoon that I think quite aptly represents what happened to black wealth in this country, what happened, quite frankly, to opportunities for black wealth. So we see segregation, we see deindustrialization, taking away many of the factory-type jobs that people had, subprime lending, and institutional racism. I'm going to talk a minute about education. So if we look at education, we see that there are educational gaps at all levels, and that as a country, we haven't figured out how to take fourth graders who have gaps in reading and math, black, compared to their white counterparts, and make up for those gaps. We are just, at this point in time, completely unable to do that. What we further see is that African American students are less likely to have access to the full range of math and science courses. You want to go to medical school, it certainly helps if you've had a strong foundation in math and science. This is a particularly important slide, partly because it is a reminder of how segregated our schools are. I live in New Jersey. New Jersey actually has the fourth highest rate of segregated schools in the country. We think about that, we would think, I would say Alabama, but no, it's New Jersey. So what do we know about these segregated schools? Well, particularly for the kids going to these schools that are greater than 90% minority, we know that 90% of the children in those schools live in poverty. So when you have a high proportion of minority students concentrated in a school, there's a high proportion of poverty concentrated in those schools as well, with all of the attendant problems that go along with that. We call this sort of hyper-segregated schools. And we see that there's somewhere between 35 and 40% of black and Latino students who go to these hyper-segregated schools, compared to about 1.5% of white students who go to these hyper-segregated schools. So we talk about fairness, and we talk about, you know, everybody should have the same playing field, and so we say to these kids, having experienced what I just described, for a fair selection, everybody has to take the same exam. Please climb that tree. And we can see by these applicants that there are a certain subset of them who will have a lot more difficulty climbing that tree. If we look in the schools, we also see another interesting pipeline that occurs. So African American students are more likely to be suspended. They're then more likely to be in residential custody as juveniles. And they're then more likely to be imprisoned. And so we see that the lifetime likelihood of an African American man is 1 in 3 of being in prison, compared to 1 in 17 for white men and 1 in 6 for Hispanic men. Similarly, African American women, the lifetime likelihood of going to prison is 1 in 18 compared to 1 in 111 for white women and 1 in 45 for Hispanic women. This slide actually shows incarceration for drug use. So we see disproportionately higher rates of incarceration by race for drug use. But on the bottom here, we actually see self-reported drug use. And the only drug that African Americans are more likely to use than their white counterparts is crack cocaine. And yet we see, again, significantly higher rates of incarceration for these behaviors. This is a tweet that came out from Donald Trump a few months back. And I show this in part because this tweet, because it comes from Donald Trump, is seen by millions and millions and millions of people in this country. And, whoops, wrong button. So if you believe this tweet, let me get back to my slide here, what you see is that he suggests that 81% of whites are killed by blacks. That's the take-home message, actually, of this. They highlight that 97% of blacks are killed by blacks. But the take-home message is also that 81% of whites are killed by blacks. Now I'll go to the next slide, which shows what the actual numbers are. And about 15% of whites are killed by blacks, and 82% of whites are killed by whites. But that misinformation in the public sector sort of continues to perpetuate this notion of African Americans as violent, dangerous people who need to be locked up. Let's go back to education for a minute. So if we look at education completed by race, the good news is actually this slide compares 1971 to 2013. And so one of the good things that we've actually been able to do is to get people graduating from high school. But when it comes time for college, we actually see the disparities continue. So that African Americans actually are significantly less likely, as are Hispanics, to get a bachelor's degree or higher. So Ta-Nehisi Coates says, the lie ignores the fact that closing the achievement gap will do nothing to close the injury gap in which black college graduates still suffer higher unemployment rates than white college graduates, and black job applicants without criminal records enjoy roughly the same chance of getting hired as white applicants with criminal records. So let's talk about education. Life expectancy at age 25 by education is 9 years different for men who drop out of high school compared to men who get a bachelor's degree or higher. And we see a similar disparity in women, 8-year gap, right, between dropping out of high school and graduating from college. One could argue that perhaps the most important intervention we could do to get people to live longer is get them to graduate from college. Just get them educated. And all that goes along with that, obviously, like a job. I want to focus on children for a moment. So 25% of children in this country live in poverty. We're number 4 in the OECD. I'll remind you the OECD actually has 31 countries, so we're like ridiculously high. We're right there between Poland and Latvia in the number of poor children that we have in the United States, that we allow ourselves to have in the United States. Because I would argue that, as opposed to Poland and Latvia, we certainly have the resources in this country to completely eliminate poverty in children. If we look at child poverty by race and ethnicity, we see that gains have been made in reducing child poverty in all groups except African Americans between 2012 and 2013. For the first time, actually, the total number of African American children living in poverty is greater than the total number of white children living in poverty. That's a first. So it used to be proportionately greater, but there were still, because there are proportionately so many more white people in this country, there were still numerically more poor white children. But black children have now overcome that hurdle. Not a great thing to overcome. I would urge all of you, no matter what your specialty, no matter what your interest, to look at the report that the American Academy of Pediatrics issued in the beginning of March this year on poverty and child health in the United States. It's a two-part document. The second part looks at mediators and adverse effects of child poverty in the United States. And basically what it shows is that poverty has direct negative effects on early brain development through the mechanism of toxic stress. The pathophysiology of toxic stress consists of frequent, unremitting activation of the HPA axis stress system and chronic elevation of cortisol, as well as inflammatory mediators. We knew that being poor was bad for your health. They just help us to understand from a pathophysiologic standpoint why. The epigenetic, anatomic, and neuroendocrine disruption related to chronic toxic stress may impair learning, behavior, and interpersonal relationships. So I want to put a frame on this. I don't know how many of you know Kamara Jones's A Gardener's Tale. Kamara Jones is the current president of the American Public Health Association. I'll add, of course, she's a graduate of the family medicine residency at Montefiore as well, so we're very proud of her. So Kamara tells an interesting story that I'm going to share with you just briefly. Let's imagine a gardener who has two flower boxes, one that she knows to be filled with rich, fertile soil and another that she knows to be filled with poor, rocky soil. This gardener has 2 packets of seeds for the same type of flower. However, the plants grown from one packet of seeds will bear pink blossoms, while the plants grown from the other packet of seeds will bear red blossoms. The gardener prefers red over pink. So she plants the red seed in the rich, fertile soil and the pink seed in the poor, rocky soil. And sure enough, what she witnessed in her garden came to pass in this garden. All of the red flowers grow up and flourish, with the fittest growing tall and strong, and even the weakest making it to middling height. But in the box with the poor, rocky soil, things look different. The weak among the pink seeds don't even make it, and the strongest among them grow only to middling height. In time, the flower in these 2 boxes go to seed, dropping their progeny into the same soil in which they were growing. The next year, the same thing happens, with the red flowers in the rich soil growing full and vigorous and strong, while the pink flowers in the poor soil struggle to survive. And these flowers go to seed. Year after year, the same thing happens. 10 years later, the gardener comes to survey her garden. Gazing at the 2 boxes, she says, "I was right to prefer red over pink. Look how vibrant and beautiful the red flowers look, and how pitiful and scrawny the pink ones are." This part of the story illustrates some important aspects of institutionalized racism. There is the initial historical insult of separating the seed into the 2 different types of soil, the contemporary structural factors of the flower boxes, which keep the soil separate, and the acts of omission in not addressing the differences between the soils over the years. The normative aspects of institutionalized racism are illustrated by the initial preference of the gardener for red over pink. Indeed, her assumption that red is intrinsically better than pink may contribute to a blindness about the differences between the soils. Dr. Jones goes on to describe personally mediated racism occurring when the gardener plucks out the pink blossoms before they can go to seed, and if a pink seed is blown into the red flower box, it is immediately plucked out. Internalized racism occurs when a bee comes along to pollinate the pink flowers, and the pink flower says, "Don't pollinate me from other pink flowers, rather pollinate me using pollen from the red flowers." So she describes 3 levels of racism being institutional racism, personally mediated racism, and internalized racism. I found it interesting that in the IOM report on unequal treatment, they offer a similar analogy, saying that there are a range of patient-level, provider-level, and system-level factors that are involved in racial and ethnic healthcare disparities that are beyond the access-related factors. So the essence of American racism is disrespect. The foundation of American racism, however, we must be reminded, comes from the long legacy of slavery that perpetuated the notion of white supremacy. Because without actually perpetuating that notion, it became very difficult to justify enslaving people for over 400 years. But if we believe them to be inferior, then we can justify, sort of, that behavior. This actually comes from the BBC, and it really talks about the hidden threat that exists within this country of white supremacy and the amount of violence, actually, that's done in this country by white supremacists. Actually, I don't know how many of you watched the program Vice on HBO, but they recently did a segment on white supremacists as well. And we don't cover them in a group as much, I think, as might be useful to understand the wide range of behaviors that white supremacists engage in this country. This is America. We want to think this is not the America we live in. We all want to believe that these people in this picture don't live in our neighborhoods. But some of them do. If we look at hate crime in the United States in 2013, we see that we still have a significant problem of race-related hate crimes. What's also interested in changing attitudes about race in the United States. And so this survey basically looked and asked people whether they thought that the recent killings of African American men by the police were isolated incidents, or are they part of a broader pattern? And we see significant differences by race. So whites, by and large, believe there were isolated incidents, about 65% of them, whereas 81% of African Americans believe they're part of a broader pattern of behaviors. Similarly, when they interviewed whites and blacks, when they interviewed people based on their politics about whether or not discrimination against whites has become as big a problem as discrimination against blacks, we see that the majority actually of Tea Party members and Republicans believe that discrimination against whites is a significant problem in this country. You can't give a talk about racism and bias without actually also talking about implicit bias. And one of the things we should be reminded about in terms of implicit bias is these are the attitudes or stereotypes that affect our understanding, actions, and decisions on an unconscious basis. These are the ways in which we decide that we will bring in James for an interview, but not Jamal, even though Jamal and James have the exact same CV because of the name. Implicit bias actually is something that's getting a lot more attention, as it should, because we are coming to understand more and more that it probably plays a role in what we see going on in healthcare. It probably plays a role in the fact that African American patients are less likely to get cardiac procedures, for example, than their white counterparts. So now I want to talk a little bit about how I think racial attitudes and implicit bias come about in this country. So I have to tell you, To Kill a Mockingbird is one of my absolute favorite movies of all time. I love this movie. I love Gregory Peck. I'm like, oh my God, Atticus Finch, he's the man. So anybody in here not seen or read To Kill a Mockingbird? Don't be ashamed if you haven't. Just let me know, because I need to do more than the shorthand I'm about to do. All right, I'll do the quick shorthand. So To Kill a Mockingbird, I think it's worth renting, by the way. It tells the story of the 1920 South by Harper Lee, right? And it's through the eyes of these three children. And basically, it's about Tom Robinson being accused of raping a white woman, and Atticus Finch's attempts to defend him from that charge. This is a scene in the courtroom at the end of the trial when Tom Robinson has actually been found guilty of the crime. But the three white children are in the balcony along with African Americans, which is, of course, where they had to sit, and they rise when Atticus Finch walks out of the courtroom because of the enormous respect for him. And they have enormous respect because he did give a really, really good try at getting Tom Robinson off, but of course he was unsuccessful. But one day I was watching this movie, and I thought to myself how different this film would have been if it had been made through the eyes of the children of Tom Robinson rather than through the eyes of Atticus Finch. Because the devastating impact of Tom Robinson's, his ultimate death, because actually after he was found guilty, he kills himself before he could be hung by the white mob. The devastating effect on the lives of those children, we actually don't think about. And then I realized that probably in the era that this book was written, and certainly in the era in which this movie was made, we weren't ready for that. We weren't ready to hear that story through the eyes of young black children on the devastation of the segregated South on their families. So then we move to a more recent movie, The Blind Side. Interesting movie about a true story, about an African-American football player who's raised by a very affluent white family when they find him sort of living in just an enormous amount of level of poverty. And this is the scene from the movie when Sandra Bullock, who plays his white mother, meets his biological mother, who has had some significant issues, and that's part of the reason why the young man is in such trouble. This is the real Michael Oher and his adoptive mother, and this is Michael Oher's biological mother. I was struck by two things with The Blind Side. The first thing I was struck by is the degree to which we never tell the story of the thousands of African-American families that take in African-American children and raise them to success. We tell the stories of white families that bring in African-American children and raise them for success. But what we also don't do is tell the stories of these mothers. What we also don't do is talk about what were the historical and familial realities between Michael Oher's adopted white mother and his African-American mother, who continues to have significant issues with substance abuse, right? Even with that, let's imagine for a moment that we didn't even take into consideration the historical realities, and we look at what are the probable types of resources available to an affluent white woman with alcoholism compared to a poor black woman with alcoholism. It's through these stories that we perpetuate notions of what race is like in this country. It's through these stories that we sometimes forget some of our realities. And so what am I doing? I increasingly am going back to Lyndon Johnson, whose reputation was perhaps rightfully sullied, but certainly sullied by the Vietnam War. And we have forgotten what Lyndon Johnson tried to do in this country related to race. And so he said, until justice is blind to color, until education is unaware of race, until opportunity is unconcerned with the color of men's skins, emancipation will be a proclamation but not a fact. We have been talking about these issues for a very, very, very long time. And I would argue that there are children in this country who are living in the same level of poverty as the children pictured in this picture with Martin Luther King Jr. Again, Johnson, Negro poverty is not white poverty. Many of its causes and many of its cures are the same, but there are differences, deep, corrosive, obstinate differences, radiating painful roots into the community and into the family and the nature of the individual. These differences are not racial differences. They are solely and simply the consequence of ancient brutality, past injustice, and present prejudice. In 1964, he declared unconditional war on poverty. And I believe that a major obstacle to us winning the war on poverty in this country is the perpetuation of racist notions about who's poor and who's not poor in this country, combined with the realities of who's poor and who's not poor. And if I don't view you as me, then I am less interested in you getting out of poverty than me. And so here we have the president of the American Academy of Pediatrics saying, 50 years ago, the US came together and nearly eliminated poverty in the elderly. It's time to do the same for children. I want to jump on this bandwagon. I particularly want to jump on this bandwagon as a family physician because what do I know? What I know is you can't eliminate poverty in children without eliminating it in the family as well. You can't have poor parents raising adequately resourced children. And so what we're talking about here is eliminating poverty in families. And one of the ways we could begin to do that is look at how we expend resources in this country. Because what you will see is that we expend significantly more on health care and significantly less on social services than many in other developed countries. And when we look at the data on what really makes a difference in life expectancy and morbidity, we make a strong argument for suggesting that maybe we ought to pay for housing and food and not quite so much for unneeded extra CAT scans, the whole body scan, all of the technology that we inappropriately use on a subset of people in this country. We also have to begin to embrace this notion of equity over equality. We're very comfortable with equality. Everybody gets the same. But in this country today, some people actually need more. And it is only through a notion of equity that we get where we need to be. And one of the things that our colleagues from San Francisco State show us is that part of what we have to deal with is discrimination and minority stressors, along with, of course, education and housing and access to health care and all of those good things. It's another way to look at it. This is what it takes. And what we have to remember is a whole generation of people counting on us getting this right. Thank you.
Hi, my name is Dr. Jesse Fields. I'm a primary care physician in Harlem. Thank you. This was really very important talk. I just wanted to mention, in terms of education, I'm on the board of directors of the All-Stars Project, which is a national program where I think the schools are failing our young people, and we have an after-school program. I think that your analogy that the poor, particularly the black poor people of color, need more. Our programs are around development and helping young people to go outside of their neighborhood, building partnerships with wealthy people, going to businesses, getting internships, workshops. We use performance So this is a very successful program. We're in 6 cities. I just wanted to mention it because I think the gap, we call it the achievement gap, I think it's deeper. It's more of a cultural, developmental lack of education, and the schools are not doing the job at all. And so we've invested in an after-school program. But thank you I just wanted to mention that. Thank you very much.
No, thank you. Thank you very much.
I appreciate your presentation, and there's so much content that you have to deliver to sort of bring people from whatever awareness they have of these issues to the finish point that you brought us to. And I often find that with teaching this content to medical students that they get sort of stuck around the issue of, like, in a one-on-one delivering care to a patient, what do I do with all of this information?
Right.
Do I assume that any black patient is, like, struggling with their historical trauma of being descendants of slaves? But I don't want to put that on people, but how do I, I don't want to assume all brown people are poor. So how do you explain how to take this broad body of knowledge and structural violence and systemic racism to what we do with people on an interpersonal basis, and how to apply this in a way that can be useful?
Yeah, great question. So let me back up actually and say why I actually started giving this talk. So I lectured literally, I'm so old, I lectured since the Heckler Report first came out. I started doing lectures on disparity at that point in time in the 80s. And so I kept doing this particularly all this data about homicide and HIV/AIDS, right? And I'm like, and one day I kind of woke up, and then I started throwing in the slides about mass incarceration, right? So the logical extension, though, is if you look at the homicide rates, then the logical extension, well, that's of course why all these black people are in jail, right? And I started saying, wait a minute, I'm perpetuating racist notions if I don't begin to talk about this disparity in a broader context, right? Because the numbers themselves can be misinterpreted to kind of validate some of the stereotypical beliefs that we have about patients. And it's similar to your question about, well, based on this data, should I assume all patients are poor, or all patients have been exposed to violence, or whatever, right? So what's the answer to that? So the answer to that is that what all of us need to begin to do is actually do a better job of documenting the social determinants issues. And we can do the University of Mexico has a screening tool they use that will be published actually in Family Medicine probably in the next few weeks. And basically, for every patient that comes in, they ask the questions, do you worry about having enough food? Yes, no. Do you have concerns about being able to pay your rent? Yes, no. Do you worry about violence in your household? Yes, no, right? So you got a bunch of people who are going to answer no to these questions, so don't worry about it. But there's a bunch of people who will answer yes to these questions, and that provides us then with opportunities, because the other thing we then have to do is figure out what are the resources. And you're in New York City, thank God, because there are a lot of resources here, certainly compared to rural Alabama. But what are the resources that we can then refer people to? Because part of us, and particularly as physicians, we're like, oh, I don't want to ask this question because then I have to do something about it. You don't. You have to know who can help you. This is my other world, is teams, right? We don't practice in isolation. We practice as part of teams. So how do we work together for the best interest? So don't make these assumptions. I think the other interesting thing is this whole notion of discrimination and how we think about people of color with discrimination. One of the things we have to remember, and this is what the poverty documentation that the pediatricians have done is so important, is it also relates to resilience. So if I come from a nurturing, resource-rich environment, typically I'm going to have more psychological resilience to deal with some of the challenges that I'm faced as a woman of color day to day. And I come from a more impoverished background, particularly if it's more emotionally impoverished. I don't have that same resilience. And so I may express very different behaviors. And so some of that is also talking about, when we get time, particularly when we have very difficult patients, what was that background like? Because that can give us windows into a lot of what we're seeing that's going on with our patients. There is not a black man in my family, not one in my extended family, who has not had a bad experience with the police. Not one. One of my cousins is a PhD physicist at the University of Iowa. The other of my cousins is a PhD chemical engineer at UC Riverside. That is irrelevant. This is reality for many, many, many African American men in the United States today. Are they overly traumatized by it? No. Because are they pissed? Yes. But they have different resources to allow them to deal with it. We have to ask the questions.
My name is Emma Ben. Thank you very much for your talk. I'm an assistant professor and biostatistician here at Sinai. And I guess one of the questions I have is when we talk about these things in terms of poverty and we talk about social determinants and so forth in our conversations, a lot of us are very much aware of the fact that these things have an impact. However, when we think about these methodologically, when we kind of go into kind of the clinical and translational research, we then kind of get into situations where we kind of measure things very wrong, or even if we measure them right, we're solely there to add these things into our models, but not actually thinking about the fact that whether or not we would want to intervene on these things.
Right.
And so can you talk a little bit more about kind of this kind of disjoint notion between having the conversation about these things,
right,
and then kind of where in the clinical and translational sector, how we actually then think about how to inform these things. So just an example. Mm-hmm. So for example, if we adjust for someone's socioeconomic status mm-hmm. at that particular point in time when we're examining them, mm-hmm. It doesn't allow for us to consider backdoor pathways, which would involve their socioeconomic status at birth, which mm-hmm. is pretty much even more important, mm-hmm. right? And so we don't actually measure those things. Mm-hmm. And so the question of the racial differences in adjusting for these things mm-hmm. doesn't even mm-hmm. Make much sense after a while. Mm-hmm. So can you talk more about how we tell people about these things, right, but then how we actually translate that into actually addressing them methodologically better?
Right. So I think there are two. I have two levels to your two answers, rather, to your question. The first answer is kind of simple to me, to be honest with you, and that is, let's get out of our academic bubble and let's start talking about this around the dinner table at Thanksgiving and Christmas, and let's talk about ending poverty in this country. Let's just take a leap. Let's just start to dream again as a country that we can end poverty. So this is not about studies. This is not about what we teach. This is about the basic fundamental humanity of our society, period, that says we want everybody to have adequate housing, enough to eat, and a good education. We could actually begin to do that. We really could. Now, let me get to the second issue. So I work with a faculty person, actually, two faculty people actually in nursing and family medicine at my institution at Rutgers, who are beginning to look at how we can measure cortisol levels in these stressed out children. And there are some people in Finland that actually figured out how to measure cortisol in hair and nails. So they're going to try to replicate that study in Newark so that we can begin to see if we can identify these children who are highly activated through poverty and violence and all of that stuff. Now, then what do we do? Well, one of the things we know, and yes, I did spend a fair amount of time in California when I tell you this, one of the things we know is that mindful meditation works. That we can lower cortisol levels in human beings through a consistent program of mindfulness meditation. So it's not like we want to find out that these kids are all stressed out and just document it and then not do anything. But the other thing we could do is we could look at, well, what else does it? Does play do the same thing? If we make sure these children have an adequate amount of play outside in a reasonable environment, could that have the same effect? That's the other piece to our challenge. So we can bring this pathophysiologic into our work as we think about then what are the interventions that we need. But I'm going to argue we really know a lot of the answer. Because this is what we also know. We know that there are a subset of very poor whites in this country who are experiencing the same adverse consequences on their health that I have described in African Americans, and we certainly know that that's going on for a significant proportion of Hispanic populations in this country who are living in this kind of poverty as well. We've got to start the conversation again about ending poverty. We don't need to study this. We know what we need to do, period. That's what I would argue.
Thank you so very much.